Bismillahirrahmanirrahim. Today we'll talk about the pharyngeal tumors. First, we're looking for the anatomy of the pharynx. As you see, this is nasopharynx, oropharynx, and the laryngopharynx. And this is pharynx. From behind you can see this is the nasopharynx, this is the oropharynx, and this is the hypopharynx. Tumors of the nasopharynx, benign lesion and malignant lesion. The benign commonest tumor is angiofibroma, nasopharyngeal angiofibroma, and the malignant tumor is the nasopharyngeal carcinoma. Nasopharyngeal angiofibroma, this is a benign lesion occupying the nose and the nasopharynx, and actually this is the commonest benign tumor in the nasopharynx, affect male only, sometimes has spontaneous regression. Tumor of the nasopharynx, the angiofibroma, the symptoms: nasal obstruction, almost unilateral, severe recurrent epistaxis, headache, and sometimes facial cheek swelling and pain. On examination, you can see the nose in the nasal cavity up to 80%. Sometimes there is proptosis of the eye and facial swelling. And in this you see this is the angiofibroma on examination, and this is the angiofibroma in endoscopic examination. Investigations is very important. CT scan and MRI are complementary for diagnosis, and sometimes we need carotid angiography for the feeder of this tumor. This CT scan, as you see, the mass occupying all the nasopharynx and the nasal cavity. And this is MRI. All you see, this is the mass occupying the nasopharynx, nose, infratemporal fossa, and sometimes extended to the middle cranial fossa. This angiography before the surgery to occlude the main blood supply. The management of the angiofibroma is surgically and preferred to preoperative embolization, and the treatment is surgical excision. The second lesion in the nasopharynx is nasopharyngeal carcinoma. This is the commonest malignant tumor of the nasopharynx, usually in elder male, and has a racial tendency for the Chinese and South Asia. Predisposing factor, Epstein-Barr virus, is sometimes environmental factor, and sometimes there is genetic cause for the nasopharyngeal angiofibroma. The site almost this nasopharyngeal carcinoma, the site is fossa of Rosenmuller in the nasopharynx. Pathology, the carcinoma is the commonest, but sometimes lymphoepithelioma or adenocarcinoma of the nasopharynx. This tumor, as a malignant lesion, has a local spread to skull base to the nerve and intracranially, and sometimes lymphatic spread to the lymph node in the neck, and the blood spread to all over the body. The symptomatology of this nasopharyngeal carcinoma is nasal obstruction with attack of epistaxis, hearing loss in one side. Sometimes cervical mass may be the early symptoms for this lesion, and affection of the skull base leads to paralysis of lower cranial nerve of the skull. The sign of the nasopharyngeal carcinoma: on examination you can see fungating or ulcerating mass in the nasopharynx, and the examination of the eye leads to secretory otitis media on one side, and when you examine the neck you can see the lymph nodes may be unilateral or bilateral in the neck. Again, the investigation for the diagnosis of nasopharyngeal carcinoma: CT scan as a radiology for determining the site and extension of the lesion, biopsy to confirm the diagnosis, metastatic work-up to see if the tumor extends outside the nasopharynx or not. The treatment of the nasopharyngeal carcinoma, radiotherapy plus and minus the chemotherapy. Now we're shifting to the other organ of the pharynx, which is oropharynx. In oropharynx, you can see benign tumor and malignant tumor. The commonest benign tumor is papilloma. It is very small lesion. And the dangerous tumor is the squamous cell carcinoma of the oropharynx. This is a photo shows squamous cell carcinoma on the left tonsil, on the right tonsil. And this is the squamous cell carcinoma is the commonest tumor. The site may be tonsil, may be soft palate, posterior third of the tongue, and the posterior pharyngeal wall in the oropharynx. The etiological factor for the squamous cell carcinoma of the oropharynx is smoking, alcohol, drinking of alcohol, vitamin A deficiency, chronic irritation, and the human papilloma virus. This tumor, commonest malignant tumor of the oropharynx, this carcinoma, usually older male and commonly on tonsil. Local spread to the surrounding tissue around the oropharynx, lymphatic spread to the lymph node of the neck, and the blood spread to all over the body. Symptoms, they start by sensation of pain in the throat radiating to one eye, sputing of the blood, and the halitosis, bad smell or bad odor of the oral cavity. Symptoms, when you examine the oropharynx, you can see this ulcerating mass and fungating mass, and when you examine the neck, there is lymph node enlarged on the neck, as we see in this photo. This is the lymph node in the neck, and this is the ulcer of the malignant tonsil. Again, investigation, CT scan and the MRI as imaging radiology very important. A biopsy to confirm the diagnosis, and after you confirm the diagnosis, you need to do metastatic work-up to see if the tumor is still in local lesion or extended to other part of the body. Treatment, surgery, and this surgery may be supplemented by radiotherapy and need red neck dissection for palpable lymph node. Sometimes this lesion, squamous cell carcinoma, the second type of the tumor is lymphoma of the tonsil, usually unilateral and not ulcerating. If we're looking for the third part of the hypopharynx, it is the pharyngeal tumor is the hypopharynx. The anatomy of the hypopharynx has three regions: piriform fossa, number 1, posticoracoid, number 2, and the posterior pharyngeal tumor, number 3. This number 1, this piriform, this posticoracoid, and this is the posterior wall of the hypopharynx. If we're looking for the piriform fossa carcinoma, it is affect only elder male, and also there is predisposing factor: alcohol, tobacco smoking, and irradiation. And this is the posterior view of the hypopharynx. This normal piriform fossa, and you're looking for the tumor inside the piriform fossa. Symptoms, sometimes it is asymptomatic and vague throat discomfort, but later on there is progressive dysphagia, pain in the throat, change of the voice, and even stridor. A sign, when you examine the hypopharynx, you can see the tumor in the piriform fossa here, and if looking for the neck, you can see the lymph node in the neck. The investigation, again, barium sorrow is very important for determining the site of the lesion and must be supplemented by CT scan and the MRI as imaging for determining the site and the extension of the lesion. hypopharyngoscopic to see the tumor and take biopsy to confirm the diagnosis, and after the diagnosis confirmed that this is carcinoma of the pyriform fossa, you need to do metastatic workup to see if the tumor is localized in this region or extended to the other. The treatment is surgical excision, and if we're looking for the last part of the hypopharynx, which is a post-cricoid space. This post-cricoid space is the space behind the cricoid and is starting at the beginning of the esophagus. So it is in the upper part of the esophagus, and it is a site for the carcinoma. And as we see from this photo, this is the tumor here, and this is the carcinoma of the post-cricoid region, and this is the larynx in front of it. Almost it affects female and sometimes as a complication to Bremer-Benson syndrome. Symptoms start of sensation in lump in the throat, and then progressive dysphagia and pain in the throat, sometimes radiating to one ear, change of voice and even stridor, and loss of weight when the tumor is in advanced stage. On examination for the determine the site of this carcinoma of the post-cricoid region, you see this is the larynx, and this is the tumor of the post-cricoid region, leads to obstruction of the inlet of the esophagus, and this is ulcerating and fungating mass. Don't forget to examine the neck, because it's sometimes the lymph node in the neck, as you see here. It is an early sign for detection of this tumor. Local spreading to the other regions, and may spread by lymph node to the neck, and may spread by blood to all over the body. Investigation plain X-ray is very important for the neck. Barium swallow determines the site of obstruction. CT scan and the MRI are complementary, and hypopharyngoscopic examination for biopsy to confirm the diagnosis. And again, after you confirm the diagnosis, you need to do metastatic workup to see if the tumor is still localized here or goes outside this region. The treatment of the post-cricoid carcinoma is total laryngopharyngectomy with reconstruction of the defect. In advanced case, you need palliative treatment, which is radiotherapy, chemotherapy, and general, you need sometimes gastrostomy or analgesia for feeding and to relieve the pain. Thank you for your attention.